Hello, everyone. Welcome to our next talk. We'll be talking about dementias and neurodegenerative diseases. A word of advice for you guys. If you haven't already, make sure that you watch the Behavioral Neurology ILA before jumping into this talk. There are a few ideas in that ILA that are going to help you understand some of the concepts that we review here. If you haven't watched it already, we'll add the YouTube link to that if you're watching this via YouTube. All right, we'll just have you guys read these objectives on your own, but basically we're going to go over some cortical dementias and then end off with some subcortical dementias, really spending a lot of time on things like Alzheimer's disease and things like that. Before we do that, let's talk a little bit about what to expect with normal aging. So what do I have to look forward to? What will you eventually have to look forward to? As it turns out, there is a normal set of characteristic changes that you can expect as you age, especially cognitively, and especially with memory. The first thing that you might notice is something that a lot of us call a tip of the tongue phenomenon. This is basically trouble with the memory retrieval. And it's an effortful recall of information. And maybe a good example is if you go to like a family reunion and you run into someone that you haven't seen in a while and you don't know what their name is, and you're sitting there painfully through a conversation with them. And then 10 minutes after you're done, when you don't need to know their name anymore, you remember, oh, that was Bob. Oh my God, that was so embarrassing. But that's what we often see with this tip of the tongue phenomenon. And the next thing that happens with normal aging is that our processing speed slows down, and that happens for just about everything. So that affects all of our cognitive domains. The one exception to everything going down and slowing down is actually our vocabulary. So for one reason or the other, over time, that improves for all of us. So I at least have that to look forward to. All right, before we jump into our dementias, there's usually a step that patients transition through, which is some sort of mild cognitive impairment, which is what we'll review here. And so the criteria that we're looking for here is this mild memory complaint without a frank dementia, relatively normal general cognition, and I think most importantly, the patient's activities of daily living, so paying the bills, feeding themselves, cooking, things like that, those are unchanged. There's going to be some objective memory impairment given their age, but I think, again, the key is that those activities of daily living are not affected. When you guys get into the clinics, you'll be hearing something called the mini mental status exam. Some people call it the Folstein exam. We do use that a lot of times to look for cognitive impairments and dementias. But in a lot of cases, especially if you're seeing someone for the first time, I find that using specific declarative memory tests. So some people will use digit span tests where they give people a list of numbers and ask them to repeat them back. Things like that are actually more sensitive to looking for things like mild cognitive impairment and other forms of dementia in a one-shot test. One thing I often do is I will have people try to memorize a short story and then give me back as many details as they can remember. So I'll give you the story that I usually use. So Bill and Tom went fishing. Bill caught a big black bass, and Bill threw it back in the lake. So I'll tell the patient that story. I'll do some other things. And we'll talk about this at a different time, but I'll do some different parts of the physical examination, do the rest of the neurologic examination, have them walk around a bit. And then I asked them to repeat that story for me. And if you think about it, there's maybe 10 or so items or facts in that story that they have to try to remember for you. And so depending on how their memory is, they should be able to remember a good chunk in that story. But if it's really bad, they'll start to lose certain parts of it. And if it's really bad, they'll go, what story were you talking about? The most important thing to remember for this group, for mild cognitive impairment, is this progression to dementia. So about 15% per year progress to a full-on dementia. Although it's not a guarantee, only about 75% progress to a full dementia over the course of 10 years. So let's jump next to Alzheimer's disease, some of the clinical features associated with that. So Alzheimer's, I think of it as a disease of the elderly. So if you're 65 years old, or if you're 80 years old, if you're above at the age of 85 and you're coming in with a memory impairment, I'm going to be really concerned that you might have Alzheimer's disease. Now, when it comes to some of the features, you're going to now have impairment in 2 or more cognitive domains. One of them is going to be memory. But if you remember the last lecture, we talked about a few findings such as aphasia, apraxia, some agnosias, and then executive function. One or more of those things will also be affected now when someone has a full-on dementia. For me, the biggest tell is going to be these patients also start to have difficulty with their activities of daily living. That's what ADLs stand for. They start to have trouble paying their bills. They start to forget to feed themselves. And oftentimes they are unaware that there is a problem. So I will say that if a patient comes in on their own and says, I have a problem with such and such a memory impairment, I'm less concerned than if their family is dragging them in and that patient is thinking, I don't know why I'm here. Obviously, these things are going to be gradual in their decline. And then as we'll talk about later, you're going to want to try to exclude other potential causes of a dementia. Now, when these patients start to have memory loss, what they initially have is they start to forget things that happened just a few moments ago. So if you remember from the behavioral neurology ILA, a lot of those initial memory formations are hippocampally mediated, and those get affected first here. So that's why you get these patients repeating themselves in conversations. They might get confused about the day and the date. So they might call their family members several times in the same hour and ask, hey, what time are we meeting for Thanksgiving? And then call again because they didn't remember having that conversation earlier on. And they, like I said before, they're also generally unaware of the difficulty that they might be having. So their ability to form new memories gets affected, but interestingly, or notably, their remote memory and their short-term, their working memory are pretty well preserved early on at least. So they'll probably remember their prom, from high school and things like that. And they might even be able to remember a phone number that you give them. Other things to look for in Alzheimer's disease, there's a subtle type of apraxia called a limb as tool error. And so what that might look like, and I'll give you an example. I might say to a patient, here's my thumb. Let's pretend it's like a nail that you're seeing through a board, and show me how you would hammer that nail. And instead of pretending that they're holding a hammer, they would use their hand and actually hit that quote nail with their hand. And you might even say, no, that would hurt, right? This is how you do it. And even when you do that, they make the same error. So that happens a lot with patients who have early onset Alzheimer's disease. These folks also have difficulty with their speech. They have what looks like a transcortical sensory aphasia. Even though the form of their speech seems okay, the content of their speech is pretty empty. And they also have something called anomia with circumlocution. So they basically have difficulty naming things. So instead of saying maybe, hey, could you please pass the salt? They might say something like, hey, can you please pass me the silver thing to put on top of this food so that it doesn't taste boring, right? And then the other thing that you'll often see is paranoid or delusional behavior. And if you put yourself into the patient's shoes, that makes a lot of sense because as far as they know, everything is totally fine, but weird things are happening. They keep losing their keys. Their family members are out and about at times that they didn't remember. So the only explanation is that everyone is messing with them. So that's how you get this paranoid or delusional behavior. As things go on, you can start to see other things. You can start to see pseudobulbar affect, which you talked about in the behavioral neurology ILA. You might see some myoclonus, some hallucinations, and you might even see Berlin syndrome develop as that Alzheimer's disease starts to affect more parts of the cortex.